Dr. Venter, you're welcome to start the webinar.
Thank you. Good evening, everyone. Tonight, I present to you Dr. Julie. She's a pediatric-focused dentist working in private practice at KiddieDent in Cape Town. She qualified at the University of Western Cape in 2020. She completed her postgraduate diploma in endodontics in 2023. Also at the University of the Western Cape, she is currently pursuing her master's in pediatric dentistry at the University of the Western Cape. Julie is currently the Vice President of the South African Association of Pediatric Dentists and a member of the International Association of Pediatric Dentistry. She is also on the Western Cape SADA committee, as well as a Nexus mentor for pediatric dentistry. Dr. Julie has a passion for kids. Please welcome Dr. Julie Resnekov. Dr. Julie.
Thank you so much. Let me share my screen quickly. Okay, so I'm very excited to be talking on the topic of management of molar hypomineralization tonight. Just a disclaimer, all the clinical photographs and radiograph used in this presentation are my own patients and clinical cases, and consent has been obtained to use them for the purpose of this presentation. So just please refrain from taking any pictures or screen recordings of these cases. So this is the beautiful practice that I work at with the beautiful people that I work at. It's called KiddieDent, and we're based in Cape Town. These are my children that we see at the practice. And I quickly just want to talk about the SAAPD, South African Association of Pediatric Dentistry, and what we are. So we are a pediatric-focused South African dental association where we promote oral hygiene and the benefits of good oral hygiene and oral health in children all across South Africa. And we do this with clinical support, CPD events, and various outreach programs, which you can see below here. So if you are interested in joining, please join. You can scan this QR code to see our website and get more information. Okay, then let's jump into it and talk about what molar hypomineralization is. So there have been various definitions for this over the years, but the one that stuck is from 2001, and it basically says that it's demarcated qualitative developmental defects of systemic origin of the enamel in one or more first permanent molars with or without the involvement of incisors. So the reason my lecture today is called molar hypomineralization is because there has been a shift towards purely calling it MH, so molar hypomineralization, and not talking about the incisors. And for the purpose of this lecture today, we are only talking about molars and not incisors. Okay, so MH is a huge topic. It's actually an entire summit worth of information. So today we're just going to do a brief overview of what MH is and then jump into some clinical cases. Okay, so to understand molar hypomineralization, we need to understand amelogenesis. And the reason is because it's an enamel defect. So to understand it and to treat it, we need to understand how it forms. So to understand how enamel forms, we need to understand amelogenesis. It's a very complex process, but I've tried to summarize it a little bit here. So you've got three main phases. You've got your pre-secretory phase, which determines the enamel epithelium and the differentiation. And then you've got your secretory phase where your enamel thickness is established. And then you've got your maturation phase where protein removal and crystal growth happens. So what goes wrong? Enamel malformations are formed from any disruption of the amelogenesis process. And this can happen at any point in the amelogenesis process. So the one thing that we sometimes see happen is hypoplastic enamel, and this happens during matrix secretion where the enamel thickness is established. And if we don't have the correct amount of matrix secretion, we end up with a pathologically thin enamel. Another area we can see a disruption is matrix resorption, and this happens when we have incomplete absorption of the matrix, and that leads to insufficient mineralization. And this is where hypermineralized enamel takes place or occurs. So we have a normal thickness, but we have a pathologically soft enamel. And that is MIH or MH. So why does this happen? It's not fully understood, but there have been links to childhood illnesses and genetic factors, but we need more research, especially longitudinal studies, to really understand what happens. So what does this look like? MIH, if we look at what the enamel actually looks like, we've got an increased organic content, which is protein, and decreased mineral density. And if you know what enamel is, which most of us do, we know that enamel is 90% or 96% minerals, and that's why it's the hardest structure in the body. So we've got increased porosity, which means we've got disorganized enamel prisms, increased interprismatic spaces, and it extends through the full thickness of enamel. And this means that patients with MIH often have sensitivity, post-eruptive enamel breakdown, and compromised bonding. So what does this look like clinically? So we often see mild MH, or we see more moderate or severe MH. So with the mild cases, it's usually white or cream lesions. It means that there's milder hypomineralization. It often goes undiagnosed. There's less porosity and there's less protein content, and in general, better mechanical properties. If we see the yellow or brown cases, that means we've got more severe hypomineralization, which means increased porosity, increased protein content, which means poorer bonding, and increased risk of post-eruptive enamel breakdown, which you can see on the right-hand side. So it's very important to understand the differential diagnosis for MIH because these cases are very often misdiagnosed. So the main culprit is often amelogenesis imperfecta, and the way we can tell the difference between amelogenesis imperfecta and molar hypomineralization is amelogenesis imperfecta affects usually all of the teeth, and there's usually a genetic history of it affecting other people in the family. But if you see it only affecting the molars or maybe the incisors as well, then it's probably MIH. Enamel hyperplasia is another one that is sometimes misdiagnosed as, and that is, if you remember from the previous slides, is when we have a disruption during the secretion phase. So the enamel thickness is less, but the actual quality of the enamel is sound. White spot lesions, so we all know what white spot lesions are, and those are when we have the start of cavities forming. And generally you can tell if it's a white spot lesion if it's relating to the plaque control of the patient and if it's on those vulnerable areas. And then fluorosis, we all know lots about fluorosis and we all have lots of experience on diagnosing fluorosis. Okay, the challenges in treating MH. So the main one is hypersensitivity. These teeth are often very sensitive due to the porous enamel, and it's also very difficult to achieve local anesthesia in these cases. Then we've also got unreliable bonding because the enamel microstructure is not the same as normal enamel. And the patient profile, because the children who present with this are often very young and their cooperation is maybe not the best, it's also very difficult to treat these cases. So there are various classifications for MIH or MH, and this one is very nice because it looks at the two main features that affect treatment planning, and it gives you a very nice treatment pathway. So these two things are hypersensitivity and post-eruptive enamel breakdown. And these indexes might look a little bit complicated, but they're actually quite simple if you work through them. So you've got one pathway for a decreased caries risk and one pathway for an increased caries risk. And we're going to talk through them now. Again, they look very complicated, but if you work through it, it actually makes a lot of sense. So the key clinical approach features that you want to look at is first risk identification, which involves early diagnosis and picking up those risk factors so that we can prevent the negative side effects of MIH if it's left untreated or undiagnosed. Then remineralization and desensitization, so that would mean fluoride treatments, fluoride toothpaste, tooth mousse applications, prevention of caries, and post-eruptive enamel breakdown, and then deciding on how we're going to treat it if we need to treat it. And are we going to do restorations or are we going to do extractions? And then once we've determined all of that, maintenance. So the most important factors to consider: early detection so that we avoid caries and post-eruptive enamel breakdown, and taking the severity into account when we determining our treatment plan, and realizing that the management of molar hypomineralization molars is different to normal molars because of the bonding, because of the hypersensitivity, and because of the age of the children. So shared decision making is very important when we're dealing with molar hypomineralization, because this is something that these kids are going to have to deal with for the rest of their lives. So if we're going to restore these teeth, they need to understand what this entails and know how to manage it and what these teeth have in store for them long term. If we're going to extract them, they also need to understand what that's going to mean orthodontically, or what that's going to mean how they're going to function without those teeth. Okay, so this is the exciting part, bringing the cases into it. So this is where my journey with molar hypomineralization started. And the reason I'm going to tell you the whole story, and I'm probably going to babble a little bit, I apologize for that, but this is a patient who is actually my nephew. He is from the UK, and he was treated in the UK for a whole bunch of cavities, but then everything went wrong, and their parents decided they were going to come to South Africa and see if they can sort his teeth out in South Africa. So what happened was the mom sent me the picture of the pan taken in the UK, and then she also sent me a clinical photo, and then a letter from the dentist that saw him. And they determined that he had molar hypomineralization, that he was going to either need an extraction or a crown, and that it needed to be done under sedation. And the reason for that was that he was busy being diagnosed with autism. He had a severe gag reflex. The tooth was very sensitive. He was very scared of needles, and he was very uncooperative. So they did not want to do the extraction, but to do the restorative process in the UK was going to cost a lot of money and they couldn't afford it. So they decided to rather come to South Africa and see if they could sort it out here. So what we did. The first thing was, I need to find out more about hypomineralization. So we did lots of research and tried to figure out what the best approach was going to be. So we did discuss extraction, but the parents insisted they did not want to extract the tooth and they wanted to try and restore it. The next was looking at what the restorative options are. So this textbook was amazing. I would really recommend looking at this textbook if you are interested in treating molar hypomineralization, and it discusses all the things that you need to consider when treating these patients. So the one thing it discussed was direct versus indirect restorations. And with all the studies that have been done, they came to the conclusion that unfortunately, because of the nature of MH enamel, there is a significantly lower survival rate of direct restorations. With indirect restorations, there is a much higher survival rate, and this is because it usually involves removing all of the affected enamel. So with the indirect restorations, this textbook very nicely outlined all the different options, including the preformed metal crowns, the lab-made crowns or lab-made restorations, and even CAD/CAM restorations. One restoration that they didn't discuss was Bioflex crowns. I think it's because they were only published after the textbook was published, but these are preformed tooth color crowns, which means sometimes parents have a higher uptake of them because they're not metal and they're not as noticeable in the mouth. Unfortunately, at the time, these crowns didn't come in permanent molar size. So what we thought we would do is just order the biggest one and hope it fits. But in doing that, the one thing we had to consider is the patient was going to be in Cape Town for a very short amount of time, and we wouldn't necessarily have the option to choose one treatment, and then if it didn't work, choose another treatment. So we had to plan for every scenario and then be able to deal with any situation that we had. So we first realized we're not going to do composite or direct restoration because he's already had a previous composite restoration and it failed, and it's very unpredictable, and the prognosis is poor. Then we had to decide we're not going to do the stainless steel preformed crown because the parents did not want to have a metal crown on a permanent tooth. We ordered the Bioflex crown, but unfortunately when we saw the patient, it didn't fit. We did not have a scanner in the practice, so we couldn't use that option. So in the end, we decided after a lot of discussion and deliberation and research that we were going to do a chairside resin crown, and that would be the best option for the patient at the time. So the way we did this, the patient arrived on Sunday in South Africa. So we saw him in the rooms quickly on the Sunday, and he was going to be booked for treatment on the Monday. And on the Sunday, we realized that the Bioflex crown wouldn't fit, and we were going to have to go with the other option. So what we did is we had booked a sedation for the patient because of all the factors that wouldn't allow for treatment in the chair. And we first built up the tooth with temporary composite so that we could take a lab putty impression, and that was our in-chair wax up. Then we prepared the tooth by removing all of the affected enamel, and then we made the chairside resin crown. So the material we used for that was Luxor crown because it's a similar concept to temporary crown material, except it's significantly stronger and it's got better wear properties. So the way we did that is we mixed it and put it into the lab putty stent that we'd made, and then placed it over the crown, over the prepared tooth. Once we'd done that, once it had set, we were able to remove it, polish the margins, and seat the crown, and it actually fit beautifully, which was great. The reason I've included the PTFE tape there is because you can see the margin of that tooth. We needed to clean it beautifully so that we would have a good seal and a good fit. So we placed PTFE tape distally to the 3/6 so that we could isolate it nicely. Then we cemented it with GSEM1, and that was the post-op the following day. And you can see how nicely it's seated. I unfortunately don't have the periapical of that appointment, but I think it's because when we took the periapical, he was no longer under sedation and he has a severe gag reflex, so we weren't able to actually get a good periapical of that. Then I haven't seen him since then, but he's been seeing his NHS dentist, and they've reported that the crown is doing very well. They promised to send me pictures and x-rays, but still haven't. But the mom sent me a picture from her iPhone a few days ago, and you can see it's still in place and it's looking good. Okay, then I just want to talk about a case. This is a 7.5, so this is MH on a primary molar. And with this case, we were actually able to use a Bioflex crown because it was the correct size. So the way we did this is we decided we were not going to extract the tooth because of the negative orthodontic side effects. The main complaint was sensitivity around this tooth, and we know that a direct restoration is not going to work very well. So what we did is a minimally invasive prep to remove all of the affected enamel and just break the contact so that we were able to seat the crown, then seat the crown, and then cement the crown. And it worked beautifully. The patient said hypersensitivity was immediately resolved once the local anesthetic wore off, and it worked very nicely. Okay, this is another case which we did. With this case, because of the apparent poor oral hygiene, the initial thought was to actually extract these teeth. When we looked closer though, and we spoke to the orthodontist said, please don't extract these teeth because he had a class 2 molar classification and an overbite. And the orthodontist was concerned that if we extract the 6s, he's going to end up with an even deeper bite and it's going to compromise his orthodontic treatment. If you look at the 7s, the furcation has not started to form yet, which means that it's not the ideal time for extractions anyway, if we were going to do planned extractions. And his main complaint was sensitivity. When we looked at the teeth a little bit closer though, we realized that his overall oral hygiene was actually fairly good. And the only area that was a problem were where the 6s had erupted. And then after looking at all his previous dental records, we realized that his oral hygiene took a turn when these teeth erupted. And the reason for that was the hypersensitivity. So he wasn't able to brush his teeth because they were so sensitive, and it was causing lots of fights and family arguments because his parents were saying they can't understand why he won't brush his teeth, and it was just causing a lot of frustration. So once we realized this, it put everything into context, and that's why he had poor oral hygiene in this area. So what we decided to do is do a similar treatment plan to the previous case, but try and see if we can improve it and make it work a little bit better. So what we did was we discussed it with the lab to see, is there not a way that we can avoid having to do a chairside wax up and see if they can actually make us crowns? So when we discussed it with the lab said that unfortunately, because this case, we wouldn't have been able to take impressions and then send it to the lab. And after we'd done the preps, because this case had severe hypersensitivity and we had limited cooperation, we were going to have to do either general anesthetic or sedation, and we didn't want to subject the patient to a second procedure under general anesthetic or sedation. So what we decided to do is send the impressions to the lab, ask them to do the wax up, and then make us stents that we could use to then make the crowns. So we would still do them chairside, but we wouldn't have to do the wax up. So we would cut out some of the time. So that is what we did. We took the impressions, sent it to the lab, they did the wax up, they made us the stents, and they sent us the model just in case. And then we did the tooth preparations, removed all the affected enamel, and then made the crowns the same way we had in the previous case with Luxa Crown. And then we cemented them on with GSM1. So this was the follow-up after 2 weeks. You can see how nicely his oral hygiene has improved. You can see the nice margins, and he was completely symptom-free. This was another case. This case was after the previous case that we just saw. But with this case, the patient's cooperation was unfortunately very, very bad, and we weren't able to take an impression of this patient. We discussed extraction of this tooth, but whatever option we did, we were going to have to do it again with some form of sedation or general anesthetic because of the patient's cooperation. So we discussed extraction, but the parents didn't want to do extraction. So we discussed the option that we'd done with the first patient in 2024, and the parents said they would like to do that. And if we think that it's not going to work and the prognosis is not going to be good, then we'll extract the tooth. So we did the same technique. We built up the tooth with temporary composite so that we had a chairside wax up, took the impression with lab putty, and used that as a stent. Then we prepared the tooth to remove all the affected enamel. In this case, that didn't cover the entire tooth. It's difficult to see in the picture, but it didn't include the interproximal area. So we just had to remove the affected enamel. Then we made the crown, and then we cemented the crown. And the patient's sensitivity was completely gone after replacing the affected and porous enamel. Okay, this is another case. This is a 10-year-old, also the main complaint, severe sensitivity, also had a deep bite and failing direct restorations. So with this patient, we also discussed the possible need for extracting these teeth. We did involve the orthodontist in this case as well, and the patients, and shared decision making, and in the end decided we're going to save these teeth rather than extract them. So what that meant was also treating all the other teeth with failing restorations. So unfortunately, this patient had quite a few primary teeth that were going to need to be extracted due to secondary caries or internal resorption. And if we extracted the sixes, it meant that the patient was going to have almost no posterior teeth left. So with all these things taken into consideration, we decided we need to see improvement in the oral hygiene. So we made a point to make the patient come for oral hygiene cleanings, and we wanted to see that there was significantly less plaque on the teeth. So the patient and the parents were very dedicated, and they did come through with that. So we spoke to another lab and thought, could we try that original plan that we had and see if we can make crowns rather than having to make the crowns ourselves and have some form of lab crown. So we discussed it with the lab, and they said that they can make hollow resin lab crowns, and then we can reline them once we're actually doing the treatment. So that's what we did. We took the impressions, they did the diagnostic wax up, and they made these hollow resin crowns. You can see how translucent they are in the photo. We also had the stents and models just in case as a backup, and then we prepared the tooth to remove all the affected enamel and then reline the crowns with genial injectable. The reason we use this material is it's flowable, but it's also very strong, and we were able to cure the genial injectable through the crown because of the fact that the crowns were so translucent. When we relined the crowns, we placed KY jelly over the preps so that it wouldn't stick and that we could remove it easily without damaging the crowns. And then we cemented them with GSM1. This was the follow-up, 2-week follow-up, and you can see how nicely they actually look, and the patient was very happy, no more sensitivity, and doing very, very well. So where do we go from here? So there must be an easier way of doing this, and we've seen a few other very interesting lectures where the other very cool dentists in Cape Town have been using CAD/CAM and 3D printing, and I definitely think that's the way forward. This is my 3-year-old son who is very naughty, and taking an impression of his teeth would be absolutely impossible, but you can see I actually managed to take a scan. So especially in pediatric dentistry, I think digital is the way we're going to go, and 3D printing would mean that you would be able to take the scan the teeth, do a diagnostic wax up, and then print the crown. And that would take a couple minutes as opposed to sending it to the lab and having to wait and everything that goes along with that. If there is anyone that is interested in molar hypomineralization or MIH, I would definitely recommend getting this textbook and reading through it. It's amazing, it's easy to understand, and it really changed the way I approach molar hypomineralization. I also just want to say a very big thank you to Terry, because he played a big role in all these cases. When we first were planning the first treatment, he sent me so many articles on molar hypomineralization and how other dentists have done it and helped us establish this technique. And to Nicolene for introducing me to this textbook, because it's really changed my life. And thank you so much. And just again, in case you forgot, please join the SAPD. It really will make such a huge difference, and I promise you'll love it.
Thank you, Dr. Julie. We appreciate that lecture. It was quite informative. So I have, if anyone has any questions, please post them in the question and answer blocks, and we will send it to Dr. Julie to discuss. Dr. Julie, just to start off with, my own little girl, 12 years old now, she also has one molar that's hypermineralized. When is the mineralization of these molars? When does that happen?
So it's in the first year of life when that phase happens. So if there's a disturbance during that time, like it could be upper respiratory tract infections or recurrent upper respiratory tract infections, then you might see molar hypomineralization. Another reason could be genetic factors. It's not fully understood, but there's definitely a link between those two.
Thank you. Then I've got one question from Benjamin De Bruin. Distinguish between amelogenesis and fluorosis. Dr. Julie?
So fluorosis is the actual enamel quality isn't the same as amelogenesis imperfecta. So amelogenesis imperfecta is very poor enamel quality, and we tend to see a lot of also post-eruptive breakdown and sensitivity and those kinds of factors. But in fluorosis, you see marks on the teeth, but not necessarily hypersensitivity. So it's definitely enamel defect, but there's less symptoms associated with it. And normally the enamel is quite hard. It's sometimes got brown and yellow marks, but it's also very often got white marks, whereas amelogenesis imperfecta doesn't usually have white marks. And the marks aren't very well demarcated, whereas with amelogenesis imperfecta, it's usually the entire tooth that's affected. I don't know if that answers the question.
Thank you, Dr. Julie. Then we've got Luhandri van Vieren that asked, what is a kiddie-friendly intraoral scanner? From my side, I could say one of the smallest scanners is the Panda Smart, which we use. Dr. Julie, what would you suggest?
So the one that I used with my son was I can't remember the exact name, but it was actually from SciVision. And the reason is it also had a very small head and it was a very quick scanner. And I should have included a video of me trying to scan my son. It was very funny. He was up in the air and down and his feet were all over the place. It was a little bit of a nightmare. So we needed a very fast scanner, and that was a quick, easy scan.
Okay. Then one of our colleagues, Mariki, welcome, Mariki. She has a question for you, Julie. Can one do a direct GI filling, for example, with E-Forte, just to help a child that has very sensitive teeth on biting?
Yes, so Equia Forte is actually my go-to as an interim restoration. It's the reason being it's one of the newer glass ionomers, so it's got a lot more the bond strength is a lot higher and the mechanical properties are a lot better, and it bonds quite well to MIH teeth. But in saying that, there's very poor predictability when it comes to MIH teeth, but that has been one of the better options. GC actually have a whole MIH protocol that they have also published, and Equia Forte are one of the main things that they advocate for. And I've seen it with our patients as well, especially in very young patients, 5-year-olds, 6-year-olds with their sixes erupting, where we just want to provide immediate relief. We can't get good local anesthesia. You can actually use ART with hand instruments to remove the very soft affected enamel, and then you obviously don't have to etch because it's a glass ionomer, and you place it immediately on the tooth and then adapt it to the tooth, and the patient has immediate relief.
Thank you, Dr. Julie. I've got a question from Stephen Horwitz. Have you considered using Stella as a restorative on these molars?
So one of my colleagues has used Stella quite a lot, and apparently it also works really well. I haven't, because when I have a case that I'm going to use that kind of a material with, my go-to is Equia Forte, but I have heard that it works really well as well.
Okay. Then we've got Dr. van Vieren again. After prepping, do you suggest any pulp capping, especially where very deep spots occur?
To be honest, I think if we had a situation like that and if you needed to do a pulp capping, that means that there needed to be an almost exposure, then I would be more inclined to do an extraction, but it depends on the case. So if the patient was quite cooperative, then maybe we could consider doing it. But the issue with that is if it didn't work, and again, it depends on the symptoms of the patient. If you're doing it in the chair, you've always got the option to coming back and doing it again. But a lot of these cases have to be done under sedation or anesthetic or general anesthetic. You don't really want to have the risk of having to come back and do another procedure and subject the child to another anesthetic. So that would play a big role. I think, again, if we had a very cooperative patient and we managed to get good local anesthesia and could do it in the chair, then yes, I would do that, but maybe not in a case where we had to do it under general anesthetic.
Thank you. There's one more question. I think you've touched on this, but let's just go through it. Oh, there's another question, sorry. The finances play a significant role, especially in the medical aid practices, and some of the parents cannot afford TA or sedation and crowns. I think you've touched on it, Dr. Julie, but what other material might you suggest for these cases?
So then,
or extraction then, as you previously said?
Yeah, it's very sad to have to do extractions purely based on finances, but that would be an option. But to extract these teeth in the chair, if you had to extract all 4 permanent first molars in the chair, that's not going to on a young child, that's not ideal. The other option, if you want to try and do an interim restoration, just to try and prolong it so that you can wait until the child is older, or so that you can wait until the 7s are at the correct age for planned extractions, then you could use Equiaforte because it does help relieve the hypersensitivity. So then I would maybe consider doing that.
Thank you, Dr. Julie. Another question. Does one need to break the interproximal margin for the chairside crowns, or does one only prepare the affected enamel? This is from Cameron Fick.
Only the affected enamel. If you can see on sometimes on the radiograph, you actually can't identify the difference between the affected and non-affected enamel. But if you follow the pattern and you see that it's only on one specific area, then you only prepare that area. If you see it's over the entire tooth, then I would prepare interproximally. But there was a case, I don't know if you remember the case that we looked at where it was only the 2/6. That tooth wasn't affected interproximally. It was only over the distal and occlusal margins. So we only prepared that area, and that immediately helped with the hypersensitivity.
Okay, then there's one more question, a little bit off topic, but I see they can see you know a lot, Julie, especially on the PED side. So they're picking your brain today. Do you ever do direct pulp capping on pediatric teeth, and when would a pulpotomy be indicated instead?
So we don't do direct pulp capping on a primary tooth. Indirect pulp capping we do sometimes do, but not direct pulp capping. And there's various reasons for that. But if we're going, the primary teeth are more inclined to resorption. So if you have a pulp exposure, then we'll do a pulpotomy. If you have, it also depends where you're doing the case. If you're doing a case in the chair, then less is more. But if you're doing a case under sedation or general anesthetic, you've got poor cooperation in the chair, you want to do what you know is going to work. So then I'd be more inclined to do a pulpotomy because I know that the pulpotomy that we do using MTA has a very good prognosis, whereas doing a very deep filling and maybe putting something over a pulp that's basically exposed, it has a poor prognosis. But again, in the chair, when you have limited cooperation, you do the best that you can. So sometimes what you do is remove most of the caries, but not all of the infected dentine, but not the affected dentine. Then what you could do is place something to mineralize that area, like a fluoride containing material, and then do a filling over that just to try and create some sclerotic dentine and avoid pulp exposure. Then maybe we would do that. But every case is different. So it's difficult it's a difficult question.
Okay, then the people are waking up now. Then there's Dr. van Wyk. She wants to know the longevity of the Luxa crowns. What would you propose to the parents? Does the longevity about these crowns look like?
So the data on Luxa crown says that the lifespan is about 5 years, but normally what we say is these are temporary crowns or they're resin crowns, and we cannot do, well, it's not advisable to do any kind of ceramic crown on such a young child. You don't know what kind of orthodontic treatment they're going to require, and that's going to complicate things. So what we do is say that we're doing temporary crowns for the time being to allow for them to continue to grow so that we can protect these teeth, but they are going to need more permanent crowns later. You also explain that no crown is permanent and every crown has a lifespan. So even a ceramic crown at some point in your life is going to need to be replaced. So the Luxa crowns have a slightly less or not as long lifespan, but generally we say 5 years.
Okay, then I think this one you've answered already, but let's just give Dr. Tamaya a chance to ask, have you ever had to do an RCT as well with these cases?
So not on a anterior tooth, but not on a permanent molar. And the reason being the teeth that because of the age of the patient, we generally see these cases on 6, 7-year-olds, which means the apices of the molar is still open. And it's just not practical to do an endo on on a child with limited cooperation with open apices and almost no tooth structure left. Then unfortunately it's one of those cases where you have to just consider the extraction and dealing with the orthodontic implications. In saying that, we wouldn't just do the extraction without involving the orthodontist, but I would explain to the orthodontist that this is not a viable solution to try and save this tooth, and it's going to need extraction, and we're going to have to deal with the orthodontic implications later.
Okay, thank you. One last question, Dr. Julie. Also, a lot of compliments coming through. Thank you, Dr. Julie, from all sides. And just one last question on material. There's one anonymous member asking, can Centrion be used as a restorative for these teeth?
I haven't used that, so I would have to actually check and then get back to you on that because I haven't actually tried that.
Okay. Thank you, Dr. Julie. Thank you, everyone, for attending this wonderful lecture. Dr. Julie, please go well, and thank you for this enlightening conversation and all the answers to our questions. We hope you have a blessed and a beautiful practice in Cape Town. Thank you, everyone.
Thank you, Dr. Julie. Thank you, Lenny. I'm ending the webinar now.
Thank you, Zama. Keep well.
Thanks. You too. Thank you. Bye.